Elevate your bodywork career with Anatomy Train's Structural Integration Certification, ATSI. Discover how to map the pattern and shape the change through inspiring lectures, hands-on body reading, and practical techniques you can use in your practice right away. Join us for ATSI Maine 2026 to 2027, where Tom Myers will personally kick off this transformative professional training. Learn more at anatomytrains.com/ATSI. At Heights Retreats, massage therapists build stable and meaningful careers rooted in wellness and care. A place where therapists are dedicated to delivering exceptional care to the guests, not to filling their schedule. Heights Retreats care deeply about their therapists, our profession, and wellness itself. Grow with Heights as they evolve into a wellness-driven future. Visit heightswellnessretreat.com for more information.
There is a question that humans have pondered for longer than most institutions have existed. Which came first, the chicken or the egg? It sounds like a riddle. It is, in fact, a framework. And like most frameworks that have survived centuries of argument, it endures not because anyone has answered it, but because it keeps revealing something true about the way humans approach origin stories. We want a beginning. We want a first cause. We want to be able to point to the place where it all started and say, there, that's where it came from. The movement science community has many versions of this argument, and they have been arguing these for decades. One in particular is this. There is a school of thought that holds that all human movement is organized from the ground up, that the foot is the foundation and everything above it is a domino effect of what happens at that first point of contact with the earth. Another school holds that the answer is the core, that central stability governs peripheral function, and that the spine and pelvis set the conditions for everything that follows. Both schools have compelling evidence, both have produced important clinical frameworks, and both, if pressed, will tell you that the other is working from an incomplete picture. The tension is worth sitting with because it reflects something important about how knowledge actually develops, not in straight lines, but in overlapping arguments that slowly accumulate into something more complete than either side could have built alone. To understand the knee, for example, we must first understand what it's being asked to do. The ankle, knee, and hip are not independent structures. They are a system, and like all systems, they are only as coherent as the relationships between their parts. The foot and the ankle are the body's first negotiator with the physical world. They absorb ground reaction force, they manage dorsiflexion, plantar flexion, supination, and pronation, and they position the tibia for everything that follows. When they are compromised by injury, by restriction, by years of compensation following a sprain that healed imperfectly, they do not simply fail. They adapt. For example, the tibia might rotate internally. The knee, which was not designed to absorb frontal plane stress or side-to-side stress, begins absorbing it anyway. The hip, working from the other direction, is the body's primary power generator in locomotion. When its external rotators are weak, or when the gluteus medius is under-recruited and the femur is not stable in the frontal plane, the upper femur collapses outward and the lower femur inward. The knee, again, absorbs the consequence. In this valgus position, it is being loaded from above and below simultaneously by two systems that are each doing their reasonable best under the circumstances. This is the domino effect that defines so much of what presents on our tables as knee pain. And the most important clinical insight it offers is simply this. The knee is a responder. It is a joint caught in the middle of two dominating forces. More often than not, knee pain is not the problem as much as it is the symptom. What this means practically is that no assessment of the knee is complete without considering both the ankle and the hip. The ground-up theorists and the core stability theorists are, in this sense, both correct. And the knee sits at the intersection of their arguments, bearing the load of an unresolved debate. It is worth noting, because it is so rarely noted, that clinical assessment is largely absent from standard massage therapy curriculum. This is not a failure of the individual educators. It is a structural reality of how massage training has historically been designed to meet our requirements, establish foundational technique, and produce licensed practitioners. The clinical reasoning layer, the systemic approach to understanding why a client is presenting the way they are, has generally been left to the therapist to seek out independently after licensure, often without a clear map of where to find it. The consequence of this is that many massage therapists, myself included, regardless of experience, carry a quiet and persistent uncertainty around assessment. There is this sense that others received instruction that was somehow withheld from them or from us. There wasn't. The gap is structural, not personal. And when a therapist does seek out assessment training, we often encounter a second barrier: the language. Orthopedic testing has accumulated over decades a nomenclature that honors its originators at the expense of its learners. McMurray's test, the Lockman test, the Thessalay test, Noble compression. These names carry no descriptive information. They do not tell us what the test is testing or why. They require an additional layer of translation that creates distance between the clinician and the actual anatomical question being asked. This distance is unnecessary, and removing it is in large part what the next portion of this episode is about. For the therapist who is newer in this field, you are at the beginning of a long accumulation of clinical knowledge. Every client you see adds to the pattern library that will, over time, become one of your most reliable diagnostic tools. The overwhelm you may feel now is not a signal that you are behind. It is a signal that you are at the start of something. For the therapist who has been practicing for years, much of what you have been calling clinical intuition is, in fact, pattern recognition, assessment by another name, built from volume and attention. The formal language may be unfamiliar, the underlying process is not. For those of us who have not memorized these tests, the most useful way to approach the knee clinically is through a working knowledge of the 4 compartments or regions of the knee: anterior, posterior, medial, and lateral, and what lives in each one. The ligaments and bursa matter, and I will acknowledge them, but they are largely passive structures. They respond to forces that muscles and movement create. If you want to change what's happening at the knee, our work is in the muscles. The ligaments and bursa tell you where the stress is landing. Let's take a closer look at each compartment. The anterior compartment is the extensor mechanism. The 4 quadricep muscles converge into the quadricep tendon, envelop the patella, and continue as the patellar tendon before inserting into the tibial tuberosity. The patella is a sesamoid bone embedded in the tendon to increase the mechanical advantage of the quadriceps. It is also one of the most clinically active structures in the knee. Patellar tracking issues, when the patella is being drawn laterally by the dominant vastus lateralis or a tight IT band, while a relatively underactive vastus medialis fails to hold it centrally, is among the most common sources of anterior knee pain. Although it can be subtle, this is a force imbalance that produces pain, inflammation, and sensations of catching, clicking, or buckling. Addressing both the overactive vastus lateralis and the underperforming vastus medialis follows. Patellar tendinitis is what happens when the tendon connecting the patella to the tibial tuberosity gets loaded faster than it can adapt, most commonly in people who run, jump, or kneel repeatedly, and almost always in the context of tight dominant quads that never fully release between sessions. It is not an inflammation problem in the traditional sense so much as it is a load management problem, which means the most useful thing you can do as a massage therapist is work the quad complex proximal to the tendon and reduce the compressive demand on it. A note to the prepatellar and infrapatellar bursa: they exist anterior to and below the patella. They become irritated under compression and repetitive loading, and they are worth knowing as a contraindication for direct pressure in an acute state. Know they are there, palpate accordingly. The posterior compartment is where the hamstrings, gastrocnemius, and the popliteus converge. The hamstrings, the biceps femoris laterally, the semimembranosus, and the semitendinosus medially, originate at the ischial tuberosity, or ischial, as my friend Joe Muscolino points out, and cross both the hip and the knee. Their distal insertions are specific and consequential. The biceps femoris at the fibular head, the semimembranosus at the posterior medial tibia, and the semitendinosus at the anteromedial tibia as part of the pes anserine tendon. These are load-bearing anchor points for the muscle group that is chronically shortened in most clients and frequently strained near those terminal attachments, a clinical reality that receives far less attention than proximal hamstring injuries and deserves more. When a client presents with posterior knee pain that worsens with resisted flexion or passive end range extension, follow the muscle from the ischial or ischial tuberosity downward. Find where the tension concentrates, work there. Because the hamstrings cross the hip, releasing them changes posterior pelvic mechanics, which changes lumbar mechanics. The chain is kinetic after all, it continues up the back. The gastrocnemius originates at the posterior femoral condyles, not of the tibia, but of the back of the femur just above the knee joint. Chronic calf tension loads the posterior knee from below. A shortened gastroc pulls on the femoral condyles from above. Follow the muscle from its calcaneal attachment into the belly and in the direction of tension. Often, the pain is a miscue and the tension lies on the non-symptomatic side. Thorough work here is key, as it is everywhere. The popliteus crosses obliquely from the lateral femoral condyle of the femur to the posterior medial tibia. It unlocks the knee at the initiation of flexion and resists excessive tibial external rotation through movement. Popliteus tendinopathy, provoked by downhill loading and activities requiring rotational stability, is posterior knee pain that is routinely attributed to hamstring tightness and routinely fails to resolve with hamstring treatment. The popliteus is accessible along the medial border of the proximal tibia with the knee in slight flexion. Work here is specific, moderate in depth, and delicate. A nod to Baker cysts. The posterior capsule can become fibrotic, and Baker cysts are a contraindication for direct pressure. Note them and work around them. The medial compartment boasts the pes anserine tendon, one of my favorite pieces of anatomy. 3 muscles from 3 different regions arrive at the same address on the anteromedial tibia. The sartorius from the anterior superior iliac spine, the gracilis from the inferior pubic ramus, and the semitendinosus from the ischial or ischial tuberosity. Together they form the pes anserine, and dysfunction in any one of them loads that shared insertion. A chronically tight adductor compartment, which describes most clients, means the gracilis is pulling on that attachment consistently. A shortened sartorius tracing its diagonal line from the hip flexors down across the medial thigh adds to that. Overworked hamstrings contribute even further. The cumulative result is the pes anserine tension or a further realized bursitis. If bursitis is ruled out, the medial knee pain presents as tender to the touch and irritation during activity, like climbing the stairs or standing from a seated position. The clinical approach follows the anatomy directly. Work the sartorius from the ASIS along the full diagonal path. Work the semitendinosus from the ischial tuberosity downward. Release the tension in the muscles before applying any pressure near the insertion, and work the adductors as a group, focusing on the most superficial gracilis. The medial collateral ligament, medial meniscus, and the medial joint line also share this location. Know where they are and work with the tissues around the area respective to any shared diagnosis. The lateral compartment most commonly indicates the iliotibial band. Remember, though, that the IT band is not a muscle. It is a thickened band of the fascia lata running from the iliac crest to its attachment on the lateral tibia. It does not respond to stretching in any clinical meaningful way. What you can do is work the structures that tension it. Superiorly, the TFL originates at the anterior iliac crest and inserts into the proximal IT band, and the superficial fibers of the glute max feed into it as well. When either is overworked or restricted, they pull the band taut from above. Inferiorly, the biceps femoris and lateral quad have fascial connections to the distal IT band, creating lateral tension at the knee. Following the lateral chain means beginning at the iliac crest, working through the TFL, the glute max, and the glute medius, continuing along the lateral thigh, addressing the junction between the IT band and the lateral quad, where fascial restriction is common, and continuing posteriorly at the biceps femoris, following these down to the fibular head. Pay attention to passive knee flexion and extension with palpatory compression along either side of the IT band. Decreasing pain and irritation at the lateral epicondyle of the femur is not direct, but more effectively achieved through soft tissue support. Listen, the history of clinical reasoning in any field is in part the history of moving from anatomical knowledge towards memorized protocols. Thinking backward from unfamiliar nomenclature toward integrated understanding is a more achievable approach. The named tests and branded assessments are not without value, but they are tools for confirming hypotheses, not for generating them. I have stated more than a few times in my career that if you know your anatomy and you know your physiology, the techniques will come. This is true for assessment as well. The established hypotheses have come from knowing the anatomy well enough to ask the right questions when a client points to a location and describes a symptom. That capacity is not reserved for any particular stage of a career. It is built incrementally by every therapist who decides to know the structure before reaching for the test. The newer therapist builds it forward. The more experienced therapist recognizes it in what they have already been doing. The kinetic chain continues, not just anatomically, but also historically.
Hello, ABMP podcast listeners. It's Kristen, ABMP's Director of Professional Education, inviting you to join us at the ABMP CE Summit Aging Clients on Tuesday, May 12th. This online event, including 3 hours of CE, is free for everyone in the profession and features courses from instructors Ruth Werner, Sheila Alexander, and Dawn Castiglione. Learn how the body changes over time, common age-related pathologies, and practical hands-on techniques for working confidently with senior clients from active to medically complex. Register today at abmp.com/summit. See you online. Precision Neuromuscular Therapy has been teaching high-quality seminars for over 20 years across the country. Founded by Doug Nelson, PNMT uses problem-solving skills and precise treatment options to get powerful results for your clients. PNMT seminars focus on honing your assessment and palpation skills to precisely target the source of your client's pain while understanding the why behind the what. Meet us in a hands-on seminar or online in the PNMT portal and let us join you on your learning journey. Learn more at pnmt.org.